Hello everybody, my name is Leslie Vasquez and today's date is February 5th, 2024, and today I am going to be presenting my case connections of Unit 4. I do want to apologize for my physical appearance today. I did have surgery earlier this week and I am just going through a bit of discomfort just around my jaw. So I do just want to apologize for that. With that being said, we can go ahead and get started. For my first case, I chose case number 3, which very briefly just describes a patient who is diagnosed with gout. And based on the clinical report of this patient, I decided that the best explanation of gout in this scenario is that the patient is suffering from decreased levels of urinary excretion of uric acid. This is the most logical explanation for gout in this case because the patient's data illustrates an increase in plasma urate with a 10.5 milligram per 100 milliliter, along with a significant decrease in urinary uric acid with a 215 milligram per 24 hours. And patients that suffer from this condition usually maintain high levels of plasma urate in the bloodstream, but very low levels of its excretion. This infers that the patient is suffering from a mutation that prevents its proper excretion, and generally it is among the kidneys that causes the reduced amount of uric acid to be excreted and an increase in the amount that is circulating. And excretion of uric acid is extremely critical because since it is a byproduct of nucleotides, it is a designated waste particle since it cannot undergo further metabolism. And if it is not properly disposed, it does cause accumulation and it can manifest to gout, which leads to further complications including swelling, joint pain, and inflammation, which is what is being described by the patient in this scenario. The other options are not does not accurately reflect this patient's data. So for the first other option was the overproduction of purines. And although this does support the patient's elevation in the plasma, it does not support why he has a decreased levels in the urinary excretion. This is because overproductions of purines result in an increase in the uric acid synthesis. This is also known as a condition called von Gierke's disease, and patients who suffer from this condition suffer from a deficiency in the enzyme glucose 6-phosphatase, and this is normally when we learn about this earlier in the start of the class, this is normally produced through pathways like gluconeogenesis or glycogenolysis. This substrate is then shunted to glycolysis or the pentophosphate pathway to increase the production of ribose, the R5 carbon sugar, ribose 5-phosphate in the cell, which then increases the production of PRPP, which is the main substrate, the starting substrate for nucleotide synthesis. Therefore, in this condition, patients will increase plasma urate and increase urinary uric acid since it is constantly being produced. Therefore, this scenario does not accurately reflect the patient symptoms. The other option was a decrease in the salvage appearance. So this one is related to the recycling behavior that is seen within purines, and this is also a condition known as Lesch-Nyhan syndrome. And patients who suffer from this condition they actually lack the enzyme known as hypoxanthine guanine phosphoribosol transferase, which is mandatory in the recycling of the nucleotide. So if the salvage appearance becomes reduced, then the uric the urinary acid levels in the system will accumulate. However, in this syndrome, it does not have a strong link to the decreased levels of uric acid. So again, this option does not fully support the patient's laboratory results, and therefore would not be an accurate diagnosis of the patient's development of gout. Additional information that can be provided to really identify the root cause of gout in this scenario are family history, along with information that provides insight on the patient's personal lifestyle or environmental factors. This is because although there is a strong heritability of gout in families, environmental conditions and lifestyle habits in the individual also play an important role. This includes alcohol consumption, if the patient is in a purine-rich diet or physical activity, or also just predisposition from other metabolic disorders such as kidney failure or diabetes. And then lastly, the scenario explains that the patient recently switched from a diet where he was consuming diet soda, and now he returned back to regular soda. So this will dramatically impact his condition with gout, because consuming, he states that he consumed 4 to 5 liters a day, and this is a very excessive amount of fructose. This is excessive even in a healthy individual. This will also elevate the production of uric acid and severely overwhelm the kidneys, and also lead to improper excretionary mechanisms. Therefore, this will also contribute to the uric acid in circulation and intensify his severity with his condition. Okay, so that concludes the first case. And the second case, I chose number 4, which basically explains a woman who is of older age who is diagnosed with megaloblastic anemia. So I state that the symptoms displayed in this patient are most likely associated with deficiencies in vitamin B12, which is also known as cobalamin. So in metabolism, this vitamin is a very essential cofactor in various pathways involving homocysteine remethylation, amino acid homeostasis, nucleotide synthesis, red blood cell formation, and it's very critical in our nervous system function. So therefore, it is essential that we maintain this vitamin within its normal range in order for its interconnections to function regularly. So initially in this case, it makes sense that the patient is experiencing signs of fatigue, loss of balance, diarrhea, and neurological complications. And it makes sense that she is eventually diagnosed with megaloblastic anemia, which is basically the malformation of red blood cells, and they grow to a very large size. This is because the red blood cells become mutated because of the loss of this vitamin that is essential in its function, and it also causes her to feel very weak. It causes her to have difficulty in walking, and swelling or redness in the tongue, as described with the patient, because the very large red blood cells are malfunctioning and therefore have reduced capability to transport blood flow and cause also cardiac stress. The other options are not accurately don't accurately reflect her condition. So for the first one, iron deficiency, although it is very, very commonly associated with anemia, with hallmarks including weakness, loss of appetite, progressive headaches, and pale skin. It, however, does not manifest to megaloblastic anemia, and this is because it does not manifest to megaloblastic anemia, which is this is what has the strong association with the weakened red blood cells, and it intervenes with the neurological function. And this is one of the main symptoms that she is experiencing, and iron deficiency, however, does not accurately reflect that. So this is an important symptom that the patient experiences that helps us identify the root cause in her condition. The other vitamin B6, this vitamin does play important roles in the regulation of neurological pathways, as it is required as a cofactor in neurotransmitter synthesis, antibody formation, and hemoglobin function. And if a patient is deficient in this vitamin, it can lead to neurological malformations. But however, this deficiency does not manifest to megaloblastic anemia. It is not observed in these patients, so this is also not consistent to what the patient is suffering from. As previously mentioned, vitamin B12 is critical for the synthesis of nucleotides and for the formation of DNA. So this is because vitamin B12 is a cofactor observed in enzyme methionine synthesis that generates methionine from our amino acid homocysteine. Methionine is shuttled for synthesis of SAM, which we learn donates methyl groups for DNA synthesis, including the methylation of DUMP to DTMP. And this conversion helps support our homeostasis of nucleotides and DNA synthesis by donation of methyl groups. However, vitamin B12 must remain in healthy levels for these processes to occur, or may lead to malfunction of DNA synthesis or accumulation of homocysteine, as it is unable to reconvert to methionine. Additional laboratory tests that may assist in the diagnosis of this patient may be supporting tests of peripheral blood smears, red blood count, homocysteine acid levels, and vitamin B12 levels. A peripheral blood smear may reveal characteristics of the red blood cells that cannot be seen without a microscope, such as their size or their abnormal shape. A complete red blood count may also help identify the quality and the quantity of the red blood cells that the patient has. So a decrease in red blood cells will indicate signs of megaloblastic anemia, since these red blood cells tend to die very rapidly, since they tend to fail very quickly as well. Homocysteine levels could support the diagnosis, because if numbers are extremely elevated, it will indicate that methylthionein synthesis is inactive and therefore cannot perform its function. And lastly, a test revealing the amount of vitamin B12 will be a direct sample of whether or not the patient is suffering from megaloblastic anemia, since it would be a direct sample if the patient is suffering from megaloblastic anemia if the count is severely low. And that concludes my presentation. Thank you very much.